Good morning and welcome to the Healthcare Authority's webinar on the Clinical Data Repository. We appreciate the time that you're spending with us this morning to learn a little bit more about this initiative. I will say as we get started that we have been out on the road talking with providers across the state. There are a number of providers who are well along in their readiness to participate and take advantage of this new tool. Equally so, there are many provider organizations who are just kind of coming up to speed and learning about this. So we have a bit of a mix today in terms of our high-level overview that some of you may have seen before, as well as some updates in terms of how implementation is going. So some of these items and pieces we cover today could be repetitive for those of you who are well along your way, but we appreciate you joining us for the updates. Today, in terms of presenters, will be myself. I'm Melody Olson, the HealthIT coordinator for the state of Washington and an employee of the Healthcare Authority. And with me is Dylan Oxford, our technical manager for all of our HealthIT initiatives, specifically the Clinical Data Repository project that we're going to be talking about today. Dylan is our key liaison with OneHealth Port with all things technical. So he will cover a number of the slides today as well. Our objective for the session today, one is to, again, continue making folks aware of what our strategy is for moving and advancing health information exchange beyond organizational EHR systems. So our providers across the community have come a long way in adopting and really becoming sophisticated in their use of the EHR system. And we're now wanting to advance the sharing of data outside of those organizational walls. Secondly, the service that we are standing up has been established to collect, share, and use health information from a variety of provider types, not only medical, but to bring in dental, mental health, and substance use information into a single record. And lastly, we want to talk about the requirements for provider organizations who have adopted and implemented certified electronic health record systems. We have put our new requirement in as of the beginning of this year, which goes into effect in February of 2017. And many providers are in the midst of making a very good faith effort to prepare their systems and their operations to contribute data to the Clinical Data Repository. So we'll talk more about the specifics of that. We'll also talk a little bit about the progress of the provider community and the work going on with the EHR vendors. So there, as I noted, there has been significant progress in expanding not only electronic health record systems, but other capabilities and tools that are in use in the community to help share information. Among the medical community, the electronic health records have really become the norm. Most of the sophisticated delivery systems have broad use and good experience using their electronic health record systems. We are seeing that not as many of those organizations have had a lot of experience exporting standard transactions. So this is a new learning curve that we're facing. We'll talk a little bit more in the technical segment of our program. In addition, on the federal side, the federal government has spearheaded a number of new standards. It's important as we try to move information from one organization to another that we're all talking about the information in the same way, that we share information that is standard so various systems can accept that information and bring it into their systems. The state of Washington has also passed through, now we have gone over $305 million in federal incentives for medical organizations who have adopted and implemented electronic health systems. Unfortunately, not all provider types qualified for these incentives. So there are a number of provider groups who are lagging in their adoption. We have a large percentage of providers who have various health IT systems, but those systems may not have the capabilities to export or consume data from other systems. Some of those types of providers who weren't eligible include very important partners in the delivery system. Our long-term care and support providers who are delivering services in the homes, in nursing homes, hospice, etc. Our mental health providers. Some of our mental health providers have these systems, some do not. The same would be true of substance use programs and facilities. Our counties, our first responders, some of our small clinics and specialists, and recently we've had some very interesting discussions with our jails in terms of some of the challenges they have with continuity of care. In addition to folks adopting the systems, I think we've also lagged in exchanging information outside of our own organizations. So in order to meet emerging needs, the Healthcare Authority is trying to fill the gap by putting a clinical data repository in place. And a clinical data repository enables us to bring information together from all different types of HealthIT systems. We're starting with those certified EHR systems who can more easily contribute data. Some of the reasons that we're doing this is that there are more organizations who are going at risk for performance, and they need information to be able to see how their population is doing, what areas of their population need additional attention. We have new organizational arrangements. We have accountable communities of health who have large networks of providers who require capabilities outside of their own HealthIT tools. We also have the need long-term for better reporting and better care management tools. The data needs go well beyond the current information available to us in the form of claims and notifications. We need clinical summaries, care plans, and various assessments to be available to all members of the care team, regardless of the setting that they're in. So some of the primary challenges is, as I noted, there are diverse care teams that need access to data. We also experience interoperability between many different types of EHR systems. In the state of Washington, as we've been passing through federal dollars for the adoption of electronic health record systems, there are more than 100 different types of vendors who are providing systems to providers. Those vendors can often interpret standards a little bit differently. So we find that it can be difficult to share information from one to another. As I also noted, there's still a large percentage of our partners in the care delivery system that don't have an electronic health record. They may have a system that they have developed or that they're using to collect information, but it's not prepared to talk with others. We find as we talk with providers that there's confusion and a lack of a shared understanding of what is allowable under HIPAA and how we work in some of the other privacy laws that are a little bit more stringent for substance use information or public health data. In addition, another barrier is just the expense of building point-to-point exchanges. A provider clinic or delivery system may have the need to talk to more than 20 different types of organizations just in their area, whether it be labs, pharmacies, hospitals, specialists, and others. It's too expensive to build a point-to-point exchange to each and every one of those to exchange data directly. And lastly, there has not really been an adoption or use of standards. Most of the certified EHR systems have the standards built into them, which is how they meet the certification requirements, but use of those standards outside of their own organization is not commonplace. Some of the reasons that this information needs to flow, and we're hearing through some of our conversations, is that we have Medicaid patients who move from one managed care plan to another, and in the course of doing that, get a new primary care provider assigned to them. They know that this particular patient has been seen outside their organization, but have no access to their clinical information. They may have access to some of their claims data, but they don't have access to their recent lab results and other important diagnostic information that can help them get started in serving that patient. So what we see are a lot of duplicative services that could be avoided. We see patients who make a visit to the emergency department, and again, the only information that hospital may have is information from their last visit there. We have health home workers providing services in the home, doing assessments for particular patients who don't have access to a full health record, which would show what the problems are that the patient's having, what recent visits they've had to emergency care, and what their total needs are. And lastly, we have primary care physicians and teams who need to be aware of mental health services and medications that that patient may be taking in a different setting in order to reconcile the full medication list. We recently learned, and this will not be new to most of you, the very special needs that jails have as someone is being taken into their system. They may not be aware of reportable conditions or active TB or specific dietary needs that a patient may have, or if they have a heart condition. So all of these types of scenarios really require us to share information beyond kind of those that we traditionally think of. Lastly, we have care coordinators who are being charged with really managing the care and services delivered to some of our most fragile clients. Those folks really need to see the broader picture as well. So with that, our strategy is to launch a multi-year initiative to be able to broaden the availability of health information. This initiative, which we call Link for Health, is part of the staged larger efforts to improve healthcare quality and better manage costs, and ultimately improve health outcomes. Recently, someone in one of our sessions said, we'll never be able to truly measure whether or not we're getting better health outcomes unless we have the clinical data that shows trends of a particular patient's health improving. So as both a collaborator and a payer, we are working to bring tools to the community, not just to meet Medicaid's needs, but that can be adopted by other organizations who may pay for services or are trying to coordinate care on this level. So just in terms of, for those of you who may not have heard of Link for Health before, we basically are deploying a set of clinical management tools through our state-designated health information exchange, beginning with the clinical data repository service. Before we can do adequate care coordination, before we can really report on the clinical information, we have a data-first strategy. So we're focused right now on engaging with organizations to bring information in to the clinical data repository. We're starting by leveraging the investments that have already been made in certified EHR systems. And these systems should already have the capability to export the data in a standard format to be able to contribute it for others to see. We are focusing on making investments that primarily provide the timeliest of information at the point of care. And we're bringing in solutions that work regardless of the EHR system that may plug into it. And lastly, we are using the existing authorities, relationships, and incentives to advance health information exchange and the adoption of these standards. So what is a clinical data repository? It's basically a large database with the capability to be able to match data to patients. So the clinical data repository has an enterprise patient matching index, which allows us to load all of our Medicaid patients into the system and using their unique identifier, be able to bring in and link data to them. It creates a longitudinal view of all care provided on a single patient. Regardless of who that patient is seeing, it's patient-centric and it's available at the point of care. That's the primary use of the clinical data repository. This is not an IT project in which we are focused on only using the data for analytics. Our first and primary view of this project is that it's a clinical project and it's intended to make the information available where the patient is, to follow them across the care setting, and to be used to improve care. Down the line, as we begin getting historical data and we can see trends, this data will be very helpful in analyzing population health. It can be used for performance reporting for providers across all lives managed by the provider. It can help our managed care organizations more easily track their progress on HEDIS measures without having the administrative burden on providers to provide information out of their electronic health record systems for those measures in which that information is required. Some of the features and benefits I've covered already. I think the most important is that this particular tool allows us to really leverage those standards for sharing clinical summaries. And I'll talk a little bit about what's in those summary documents in a few minutes. And it supports clinical data exchange for organizations that don't have similar platforms or don't have electronic health record platforms at all. We are really needing to meet providers where they are. So all providers with electronic health record systems that are certified can contribute data to the CDR. Providers without those systems will have the capability to view data within the CDR, and we'll be looking long-term at additional capabilities to help them contribute data as well. It provides a common place to share information for organizations that are participating in new arrangements and new relationships. Some of the benefits we see is that the practitioners have told us that they do not want to leave their own electronic health record system to go out to the state and locate different data sources. So the solution we're putting in place with the clinical data repository will allow them to do this directly from their electronic health record system and then view the data using their current workflows. It doesn't require a provider to remember that data has to be exported to the CDR. That is being built into the business process, where each time a Medicaid patient is seen, a summary is automatically exported to the clinical data repository. So we have entered into a unique partnership with an organization that many of you are probably already using and may not know what exactly the relationship is behind the scenes. So the OneHealth port was designated through a legislative process as the state's lead health information exchange and has been working with provider organizations for many years, delivering many different types of services. One that many of you may be aware of and they're best known for is their single sign-on service. So those of you who access Provider One billing system now do that through the single sign-on service through OneHealth port. So many of your organizations are already subscribers of their service, and if that's the case, this additional service of having access to health information in the clinical data repository comes at no additional cost to you. It's part of the subscription you already have. If you don't already have a subscription, then this would be a new service that we can certainly talk about the process for initiating that in a few minutes. So the first phase of the health information exchange at OneHealth port was really data transformation and routing, so moving data from one location to another. The second phase of the health information exchange is to stand up a clinical data repository service, which is in direct response to increased interest in this type of health information exchange. So how does it work? The service is operated by OneHealth port, connects the different systems, gathers and combines the information. The Healthcare Authority is the first customer of this service, and we are adding our Medicaid lives as the first group of patients that we will be monitoring. We also intend at a future date to add our PEB-covered lives, and we know that there are other customers who are currently using this service, preparing to using the service, and considering joining the service. It's established to collect, share, and use health information from a variety of different provider types, and to make available the viewing of health records through a clinical portal for those without sophisticated technology. Earlier I talked about moving to standards, and I just want to focus on one standard. There are many transactions that over time will be implemented through the state health information exchange and connect with or interact with the clinical data repository. The primary standard for sharing information, exporting it from an electronic health record and sharing that information with a clinical data repository is what's known as a CCDA. We're not going to get into the technicalities of this standard, but I will tell you there are certain high-value data sets that are shared, important information components that different trading partners want. You see the list on this slide of some of the important things that you may want to know as a provider when serving a new patient. What are their allergies? What medications are they on? What are their primary problems or diagnosis? What procedures have they recently had? And what are the results of some of their more recent diagnostic tests? What immunizations have they had? Is there a plan of care? What are their vital signs? What has the history been? You'll see some of the other pieces in terms of payer information, patient demographics, medical equipment, and their functional status. All of these types of information are important when providing whole person care, and it's important that this information come from a variety of caregivers. So how does the data flow? You'll see on the slide that a provider organization who has a certified EHR, you'll see in the upper left-hand corner, is connected to OneHealth port using the standard protocols that we've talked about. The provider's electronic health record pushes a standardized summary document, the CCDA that we just talked about, to the clinical data repository through OneHealth port after each encounter with an Apple Health or Medicaid patient. These clinical documents for that patient are then aggregated in the clinical data repository. As we begin gaining critical mass of data, it will then be possible for that provider to look up or query against the clinical data repository through their own EHR. The Health Information Exchange will then send them any relevant information on that patient, and that can be done before the provider even has that encounter. This gives the provider access to the most current and comprehensive information that that patient has. For those without a certified EHR or without any type of electronic health record system, they will be able, authorized providers will be able to come in through a secure web portal to be able to look up a patient and view their information. So on a very basic level, that's how it will work. There are a number of roles and responsibilities and organizations involved in preparing to launch this initiative. The first role is the sponsor, and in this case, the sponsor is the healthcare authority with our managed care partners as sub-sponsors. Together, we pay for the setup of our Medicaid lives, the loading, the testing, ensuring that our access policies are accurately reflected, and we pay to maintain the record of each life in the CDR. We control the policy to the data, which would include access, retention, those types of things. The second player in this would be folks like yourself, trading partners. These are hospitals, practices, providers, anyone who is delivering services to a Medicaid patient. They not only contribute data to the clinical data repository, but they also draw data. They must be a participant in the OneHealth port HIE. As I noted before, our HIE operator is OneHealth port. They manage the health information exchange, and they set up the clinical data repository for our Medicaid lives based on the policies that we define for them. Lastly, and very importantly, are the electronic health record vendors. They need to work with providers to ensure that the standard format that is being exported from their system meets the national standard. They test that to ensure that that transaction can be accepted and imported into the clinical data repository. They set triggers within an electronic health record system to identify a Medicaid patient and to be able to trigger the data submission to the CDR. They are very important partners, and it's important that the Healthcare Authority and OneHealth work closely with them, particularly those who are working with certified systems to ensure that things are moving appropriately and they're meeting the standards. So why are we launching this now? We believe we've really reached the tipping point in terms of the number of providers who have the clean and mature data to share. We are trying to meet emerging needs as we move into more advanced and complex activities to reform healthcare. And we want to move the community together to reach critical mass. If I'm the only organization contributing data to the clinical data repository, the data there is of no value to me until other partners across the care community are also sharing their data. So our intent is to move the community at one point and gather enough information that folks can feel confident that they have a nearly complete record as they're making care decisions. The other reason to launch this now is providers who are working to obtain incentives for advancing their use of electronic health records in the Meaningful Use program are having difficulty meeting some of the objectives that have been outlined to get ongoing incentives. We refer to these as stage 2 objectives. We'll talk a little bit more about those in a moment, but one of those is the moving of care summaries and sharing that information with providers who have different systems than they do. So this is one strategy that we hope more providers will be able then to acquire additional incentives. So in order to try to move the needle on a very broad scale with a lot of providers, we are using both our existing contracts as well as our incentives. In the beginning of this contract period with our managed care organizations, they inserted language that they would require when their subcontracted providers see a managed care enrollee, they would send a care summary from their electronic health record to the clinical data repository beginning in February of 2017. The Healthcare Authority and the managed care organizations are not requiring this of anyone who does not already have a certified EHR. We are not expecting providers to go out and make further investments. We're looking at providers who have already attested that the systems they're using meet these standards. One of the objectives that participation in the clinical data repository that can be met by participating is objective number 5, which is known as health information exchange. In prior versions of the Meaningful Use Rule, it was known as the Summary of Care Objective. The basic requirement is that they need to be able to use their certified EHR system to create a summary of care record and electronically transmit that summary to other providers. Contributing data to the CDA or to the CDR adds that information to a patient record and makes that information available to other authorized providers. We believe, and CMS agrees with us, that by contributing data to the CDR, providers can meet this objective. The other objective that providers will be able to meet as they're able to look up information and receive information back from the clinical data repository is the objective 7, which is around medication reconciliation. So this one can be met by looking up data, and it's particularly helpful as we add mental health information to the clinical data repository where you'll be able to see medications you wouldn't have had access or visibility to before. Again, HCA believes and CMS agrees that by bringing information in from the clinical data repository, this helps overcome some of the interoperability challenge and helps providers meet the measure. So who are we requiring and our managed care organizations requiring to submit data? You'll see this decision tree where basically the first question is, are you subcontracted with a managed care organization to serve Apple Health patients? If the answer is yes, and you have an electronic health record that is 2014 certified, then you must begin submitting data to the clinical data repository no later than February 1st, 2017. Now that may seem a long ways off. We announced this requirement back in January of 2016 because we recognize that providers need time to work with their vendors to make changes in their system. There are a number of providers who are well on their way to meeting these kinds of objectives. To date, before we move off this slide, to date we have 89 organizations who are attending OneHealth Port provider webcasts, in addition to those who are joining us today. There are 112 vendors who support provider EHR systems who are attending the technical webcast, and there are 36 organizations using 24 different vendors who are engaged in their readiness activities to contribute data. Those 36 organizations represent 1,360 facilities. So you can see that as these organizations start contributing their data in February, we will quickly get to critical mass and getting good, significant data. If you don't meet these two questions on the right-hand side, then you are not required to participate at this time. And by participating in this context, we're talking about submitting data. You will be able to see data as soon as that data begins flowing in. Often as we give presentations, folks will ask us how we're able to share this information, given the privacy laws and so on. We are setting up the clinical data repository as an extension of our Medicaid management information system. As such, all patients who are receiving Medicaid services will be placed in the clinical data repository. They will be able to opt out by consent for special services that require consent. So for example, for substance use, the same rules apply as they do today, that in order to share information, a patient will need to sign consent. So for basic health information that's covered under HIPAA for treatment, payment, and operations, all patients are automatically in, and we will be sharing information as you do today. So I am now going to turn over the slides, which I think I should have done a couple slides ago, to Dylan, who's going to talk a little bit about some of the technical collaboration that's going on with OneHealth Port, with our providers and our vendors, and perhaps share some of the challenges that are being reported to us through our work in those areas, and maybe extend a little bit on things that we are considering to be able to help move this along. So Dylan, I'm going to turn it over to you at this point.
Thank you very much, Melody. As Melody mentioned excuse me, in a previous slide, we are working very closely with the State Health Information Exchange, OneHealth Port, on bringing this CDR to fruition. And a major component of that is that OneHealth Port is one of our primary technical resources here, and we're doing a lot of collaboration with them to accomplish these goals. One of the key constraints we have with the CCDA transaction is applying the confidentiality classification codes, and we'll get more into that in just a little bit here. The other pieces that OneHealth Port is very strongly promoting with the providers is, in order to limit the impact on the provider workflow, setting up an automated CCDA process so that data submissions do not need to be interacted with by a provider or anyone at a facility, as well as setting up some of the query functionality so that your EHR system can populate data on a client when you've never seen them before. OneHealth Port is also supporting providers in testing and onboarding activities. And to get started with all of the work that OneHealth Port will be able to help you with, please go to the website listed on this slide to start with the readiness activities. For the data classification codes, the CCDA transaction provides a confidentiality code which allows you to classify the data being submitted on the transaction as normal, restricted, or very restricted. All of the data contributed to the CDR from the sponsors as well as the information coming from the providers has to be classified to ensure the confidentiality and integrity of all patient information. This data classification conforms to the HL7 national rules and is part of the standard CCDA transaction. And every organization contributing data is responsible for their own classification system that they use for the data that they are submitting to the CDR. Briefly to talk about the classification codes, a code of N, or normal, represents sort of standard everyday health information, a brief doctor's visit for a sore throat, you've sprained your ankle, something along those lines. Whereas restricted information has to do with the potential for stigmatization from the information coming across on the CCDA. For example, this could be related to a doctor's visit for alcohol abuse. Very restricted is the more rare of the classifications and is used when there is a high potential for stigmatization if this sensitive data is seen by more parties involved in the healthcare planning of a client. That could be something such as treatments related to child abuse. All data on a CCDA transaction is classified at the highest level of the one element in the data that may have a higher restriction. So for example, if you happen to see a doctor for both a sore throat and potentially for alcohol abuse, the entire document will be classified as restricted. To give a little bit more of the background on why those restrictions are so important, the classification goes into a lot of our access control policies that we have made as a sponsor. And we made that decision mostly due to the classification code, the confidentiality code, being one of the few available triggers within the CCDA document that a provider or a vendor can set up business rules to control and it be used for the access within the system itself. So as we develop the system more and provide more rules for the providers and vendors to use, we'll show how these confidentiality codes affect the access policy of the system. There'll be more information on that coming at a later date.
I'd like to add, Dylan has done some excellent work on this area. There were over 1,800 different codes, or different
billing codes.
Different billing codes in which he brought together a group from across Department of Social and Health Services, Department of Health, and the Healthcare Authority, and brought our clinical leadership together to determine for the data that we're contributing from the claims, how do we classify the data, normal, restricted, or very restricted? Which of those pieces do we need special protections around? And he's done this work with the intent of publishing a white paper in which we will be rolling out in an upcoming meeting with a subset of providers who brought us this issue initially, the challenges in doing this. But the white paper will outline the methodology that the state of Washington has used and our clinical leadership has approved in applying these codes. And we're hoping that that can save the provider community time as they look at their own activity. What we've learned from providers is that, and this makes total sense at this stage of maturity in terms of sharing information very broadly, is that most of the electronic health record systems have been set to default to normal, that all data within the system is identified as normal. And they're able to restrict access to folks not authorized to see some of those more sensitive data elements in other ways through their own access policies. Now that we are asking that that data be contributed to a much broader pool of data, which will be accessible to lots of different types of folks giving care, we need to be sure that some of that information that should be more restricted is in fact labeled as such. So we recognize that providers are now going through an activity to work with their vendor to look at the rules of how they will apply these classification codes. The EHR systems, if they are in fact certified, as folks have attested to, should already be built to accommodate the N, R, and V classifications. It's just that those may not have been used since the data has not been shared very broadly externally. So this was raised to us by a group that is making some really good headway in their readiness activities and working with OneHealth Board and the Healthcare Authority to identify some of the early implementation challenges and making sure that our policies, in fact, are well thought out and will support patient privacy, which is of the utmost importance to us. So I'd like to, in a moment, take a look at some of the questions that may have come in, but at this point, I do want to let you know that if we aren't able to answer all of the questions, or we need to give a longer, more thoughtful response than can be done during a webinar, we will be taking a look at questions that are not only submitted through the chat boxes, but also we have a location that we would like you to send questions that maybe require a little bit more detail than you want to put in the chat box. If you email us at healthit@hca.wa.gov and you put HIE in the subject line, we can triage and sort those questions and assign them either to OneHealth Port if they require a more technical answer than we're able to provide, or to the right team members here on our HealthIT team. We track each of those questions that come in as a ticket so that I can ensure our team is following them to closure. So we would encourage you to do that. At this point, we're going to look at a couple of the questions that we have that are coming in. Is it possible to get the slides ahead of the webinar? Well, it looks like we've already missed out on that piece. We will send the slides after the webinar. I'll tell you, we were making last-minute changes right up until the broadcast to make sure that you had the most up-to-date information. We've also gotten a comment that this will be a huge help in delivering care to foster children. We have heard that often foster children can move locations, move to new primary care physicians, and it's really important that their record follows them. And as they age out of foster care, being able to have those next set of providers or health providers taking care of them have access to those records. How do small public health clinics fit into this? So this is really an interesting question. We have had very recently had discussions with the different public health jurisdictions because we believe not only can they contribute data, but it will be important for some members of those offices and groups to be able to have access if they have a business need for treatment, payment, and operations. And we also know that for public health purposes, there are often times where public health officials can have access to information. So we are working through those now. We would envision that folks who are authorized to have that information would start by coming into the clinical portal where they would be able to look up a patient as needed. We are also looking into bringing other public health data into the clinical data repository when a patient is looked up. There's a lot of interest in having access to immunization data or data that might be in a cancer registry or reportable conditions. So there are a lot of those types of details that we're still working through. Our focus primarily now is getting the medical and mental health data ready and prepared to start feeding into the clinical data repository, while at the same time, on a parallel path, we're looking at some of these questions as well as how to prepare and cover consent for the substance use data. So over time, we will add more data sets and expand the type of information that will be available.
We have a question asking whether there will be automatic downloads of data from the CDR if the system recognizes that you have a previous relationship with the patient. It's a good question. At the moment, the system is not designed to send unsolicited data on previous relationships, but we can discuss whether that is something that could be useful for more of the providers involved. There will be a way to set up a trigger from your system that, say, during the pre-admit phase, that it sends a query to the CDR to see if there is data there to be drawn back in.
The next question is whether or not there, for those who may have missed a portion of the webinar, or perhaps you know someone else who may be interested in this presentation who couldn't join us today, we are recording the webinar, and within a few days we will post that on our website. The location of our website is on the last slide, so as we distribute the slides, I would check back in a day or so, and we would have a link to the webinar where you could hear it again or forward it to someone else. The next question is around getting approval from CMS on us being able to ensure that folks can meet the stage 2 criteria for meaningful use. And we have, on prior slides, we've used the words "we are seeking approval." We do have formal approval back from CMS. That is one update that we need to make in the next round of slides. But we will not have it completely wrapped up until we submit our state health, it's the State Medicaid Health IT Plan, or SMHP, which we'll be submitting in February. But we have received verbal notification and email notification from CMS that they do support this, and for us just to submit it in our state SMHP. Let's see. So there's also a note that folks are receiving conflicting information regarding the confidentiality information. Told that these may not be required, and has that decision been reversed? So the Healthcare Authority has, from the beginning, stated that the confidentiality coding will be required. This is necessary for us to have integrity around our privacy and security policies. We did have folks come to us and ask us to reconsider that policy, primarily due to the level of effort that it will take providers to move their current classifications, which are all defaulted to normal, to reflect the restricted and very restricted. So we are still, our long-term goal and our policy is to require those. We are considering and floating some language here internally with our sponsors as to whether or not providers could have the option of taking a little more time with the data that needs to be classified, restricted or very restricted, and segregating and submitting just the data that really should be classified as normal in this first stage in February. So more information will be coming out on that. We are not going to be moving off the policy of requiring it, but we may defer when the restricted and very restricted comes in. And Dylan is working a little more on that. Could you speak to that, Dylan?
Yeah, and one key addition I'd make here is that the confidentiality element is a required element of the CCDA transaction. So your CCDAs will be submitted likely with the default of normal in most cases. So what we're working on are the options for providers that can't get to the type of definition to switch between normal and restricted and very restricted depending on the circumstance of the visit. So what we're trying to flow through and get through is getting the normal data that providers can submit now without making those type of business rules for their system, and then working on restricted and very restricted data at a later point.
So overall, the policy stands. The deadline for restricted and very restricted data may change, but more information will be published on that. Thank you for your question. One of the next questions is, are there any penalties to organizations that are not meeting the requirement to submit the summaries by February 1st? And what are those penalties, if there are any? You know, we are trying to implement this because it is the right thing to do and it is helpful for providers while they're delivering care. In the beginning, we do not plan to impose penalties. That said, we will be adding post-payment reviews as part of our post-payment audit processes for providers who are receiving meaningful use dollars for these certified systems, have attested that they are able to export these transactions. And we will be then considering whether or not there will be any penalties in the post-payment audits. We will not start doing those audits until after February, but if providers truly are meeting meaningful use and they're attesting that they have certified systems with these capabilities, we don't see any reason to continue paying incentive payments to those organizations if they're not participating. Managed care organizations are really the ones who have the direct contract with providers. It's in their contract language. At this point, we are all working to try to support providers to move to this and not focusing on any type of a penalty phase. So I think, you know, right now, if an organization truly cannot meet the deadline of February 1st, I would suggest that they send a letter to us on their letterhead signed by a leader in their organization asking for a consultation with us. We know that most providers are making a good faith effort to meet this deadline, and so we would like to work with folks and we would like to support folks in meeting the deadline. So we'd like to hear from you if you have specific circumstances that you think we need to discuss. We also have a question, is it our experience that EHR vendors have already developed these types of rules or triggers for sending data automatically and that they're ready to go? I would say that our vendors are all over the map. Some have been anticipating this type of need and functionality. You know, the whole intent with meaningful use and trying to get the standards in place and the certified EHR systems in place was to enable these types of transactions to take place. So I would say that we're finding some of our vendors have these types of things all ready to go, and some are finding that it's, you know, they're going to have a little bit of work to do. Are there plans to extend this to non-Apple Health insurance plans? That's a really important question. One of our strategies as we were considering a clinical data repository for Medicaid was that we did not want to build another siloed system behind the state wall just to meet our own needs. That there was an opportunity for us to work with OneHealth to bring a community asset forward in which any payer who wants to be able to use the clinical data repository service can do so. And they would just be required to, you know, pay for the lives that they sponsor there. This is what would really be ideal from our perspective, is that if it becomes a multi-payer solution, which it has the capability to do, and there are other groups already looking at this and in talks with OneHealth, you truly then get to a longitudinal record because people move in and out of Medicaid, they move to other payers, and there's certainly value for this tool on a broader scale. Our hope is that given the number of lives that we were sponsoring in the CDR, that we were able to negotiate a low cost based on volume that other payers and other groups can take advantage of. So there definitely are opportunities here that we hope other people take up on. So I want to thank you for your participation today. We may not have been able to reach every question, but at this point we are going to close the webinar. And again, if you have specific questions or other feedback that you'd like to share, please send that to healthit@hca.wa.gov, and we'll be able to track your question and your specific scenario to closure. With that, we're going to sign off, and we look forward to another update coming up next month. Thank you all.